Happy Wednesday, and welcome to today's presentation titled Trends in Psychiatric Beds Capacity. Before we begin, we would like to remind you that this is a safe and friendly space for positivity and productivity. There are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. This information will also be available on NRI and NASMHPD's websites and NASMHPD's YouTube channel. Please use the chat pod to share your name and state, ask questions, and/or share information with the group that pertains to this presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We will also have an ASL interpreter who will be spotlit on your screen. When the presentation ends and you leave the meeting, a brief survey will show in the browser. Please take a few moments to share your comments and thoughts about today's presentation. We would like to give special thanks to SAMHSA for sponsoring this presentation, and thank you again for joining us. I will now turn this over to Ted Lutterman to begin. Thank you.
Well, thank you, Kelly. So I'm Ted Lutterman. I'm with the National Association of State Mental Health Program Directors Research Institute. So we're a nonprofit that was spun off from NASMHPD over 30 years ago to focus on data collection, policy analysis, and evaluations related to the public mental health system. So we've been working with states for many years to try and document what they're doing with their overall public mental health system, and state hospitals and other psychiatric inpatient is a critical part of the system for people with the most serious needs. I do want to go over just basically this disclaimer that the views, policies, opinions that I'll be talking about today reflect the authors of this paper. They're not necessarily SAMHSA's or the Federal Health and Human Services Department. The information I'm reporting on today is from a report we wrote last year for NASMHPD and SAMHSA. The full report is available on the NASMHPD website. The paper Trends in Psychiatric Bed Capacity was one of a series of 10 papers that were produced and is part of a series called Beyond Beds that NASMHPD's been doing that focus on the role of inpatient care within the larger behavioral health services continuum. So many of the recent TAC papers focus on crisis services, 988, and programs that can divert individuals from emergency rooms, jails, and inpatient to less restrictive, most appropriate level of care, and thus keeping the state hospital and other psych beds available for the few individuals who need this most intensive level of care. Today, the paper is going to sort of review trends in the use of psychiatric beds over the past 50 plus years. And I want to discuss some of the common myths and reality about the closing of beds over time. And so the paper and also includes some state-by-state trends and data that's available. And if some of the states are interested, we can provide you some spreadsheets or stuff that have data for your state over time or for other states that would be helpful. Also, I'm joined today by a colleague from the University of North Carolina, and Kristen's going to talk about an exciting new project that was developed by the American Psychiatric Association, helping to develop a model for how many beds are needed that really takes account the overall system. So looking at if you've got a robust crisis system, if you've got assertive community treatment, robust community services, that impacts how many beds you need. And she's going to be talking about that model and some of the early testing of it. So if you're not able to stay on for the whole call, which I hope you will in order to hear Kristen's part, some of the key take-homes, there was a 17% increase in overall mental health beds from 2010 to 2018. So we hear a lot about shortages of beds, but there was this increase going on, and it was a major shift in settings. So private psychiatric hospitals had a large increase in beds, and same thing with general hospital specialty units that were up 25%, while state hospital beds patients decreased by 18.5% from 2010 to 2018. And that really shows the subnote there, from 1970 to 2018, there was a 90% decrease in beds. But during that same time, all the other psych beds increased by 50%. Another major point, though, was while adult beds increased, the SAMHSA data shows a decrease in kids' beds by 20% over the 2010 to 2018 time period. And we're really hearing that from a number of states, at least anecdotally, that there's a particular difficulty getting services for kids with complex needs who need intensive inpatient or residential care. I do want to point out, while the state were downsizing their state hospitals, that they increased community mental health services and expenditures by over 25% during that time period. There is some 2020 data available, and shortly there should be 2022 data available from SAMHSA. But for this report, we really didn't think we could use the 2020 data because it was collected just as COVID was starting with the lockdown. And so we think that data, which does show a big decrease in beds, part of it was a temporary decrease due to COVID, where they closed units or stopped taking people. Part of it was also there was a lower incomplete responses to the survey because of COVID. We talked to one state that had several of their state facilities weren't showing up in the data at all. And there are probably some actual permanent closures of beds that happened as a result of COVID also. But we think that we're going to really need to look at the 2022 and later data as we've got out of that COVID piece to really understand that. So one of the things I want to focus on is, often the discussion of psychiatric bed capacity focuses on this decrease in state hospitals. In the 1950s, there were over 550,000 people in state hospitals. Today, it's less than 40,000 patients on a given day. But these discussions really focus on all the other beds that have been developed and come a long line since then. And also, the role of state hospitals today is very different from the population that they were serving back when they had 550,000 patients. So as a result, a lot of these analyses sort of overemphasize the impact of state hospital closures. They don't account for both the huge increase in community-based treatment, the crisis services, or all the alternative beds that aren't run in state hospitals. And so that's really what we're going to try and look at today. So, psychiatric bed shortages are frequently in the news. They're a focus of courts, advocates, providers. This is a set of headlines that I just found searching within basically a 2-month window. They come across the country, waiting for treatment, shortage of beds, leave people in jails, teens sleep in emergency rooms every night. I'm sure in every state you probably have some sort of a headline around that. What we hear from states, is, often though that message is a little too simplified and they focus just on the state hospital. Decreases in psychiatric inpatient beds are, blamed for increased homelessness, for people in jails, prisons, increased boarding in emergency rooms, violent crimes, increased suicide rates. What was interesting is this isn't just recent claims. It was in 1984, the New York Times listed the closure of state hospitals as a cause of homelessness and incarceration. So it's not a new phenomenon. This is an example of a chart that we see often. This was tweeted out. Dr. Insel actually did this. It looks at the number of people that were in state hospitals and tracks it from back when there were a little under 500,000 people in 1960 to today, where there's less than 50,000 people. And then it compares it to the number of people in jails and prisons. And I want to come back to this slide in a little bit because this really, I think we need to make some adjustments to this slide to really address both who's in jail and what were the replacement of these inpatient state hospitals. If we look at the number of states that were expressing they had a shortage of beds, we've seen over time a growing number of states report experiencing a shortage in state psychiatric in beds, both in state hospitals and in other settings. If you're not familiar with the acronym SMHA, it's the state mental health authority in each state. And what we see, in 2010, 13 states had had a shortage of acute beds in state hospitals, and it grew to 21 states today. For other psychiatric inpatient settings, though, there are even more states reporting a shortage of acute care. And then the same thing for long-term care. The number of states expressing a shortage is growing. One of the things you'll see is for long-term care and forensics, the state hospital is more this situation where states are looking at shortages as opposed to other psychiatric inpatient settings. General hospital psych units, private psych hospitals are increasingly used for acute care in lieu of the state hospital. In the result of these shortages, we've seen an increased number of states that are reporting that these shortages result in increased waiting lists for care in state hospitals, increased waits for beds in other psych hospitals, resistance to closing more beds, increased overcrowding in state hospitals. We're a little surprised that more states didn't say increased reliance on emergency departments. And several states mentioned that people are sent farther from home, particularly for kids. We're hearing kids are being sent out of state because they can't find a placement in state. But one of the interesting things is we ask states what are they doing to address these shortages, and they're really not focusing on reopening closed state hospital beds. States reported a variety of policies to address shortages. A lot of states are really focusing on expanding the use of crisis services. Last summer, we went nationwide with 988 as a crisis lifeline call center. States are implementing mobile crisis teams, crisis stabilization centers. These are all designed to help divert individuals away from inpatient care, get them the most appropriate level of care that they need. But the crisis systems found many people don't need to go to an inpatient bed if they get appropriate crisis services. A number of states are working with local hospitals, both private psychiatric hospitals and general hospitals, to open beds. There's increased use of assertive community treatment teams and other supports to avoid hospitalization or rehospitalization. Shifting funds from the institutional settings to community to decrease admissions in the state hospitals. We hear states doing things to develop housing and supports for people that leave the state hospital so they don't come back. And changing statutes or policies to permit forensic evaluations and services to be done in the community. So outpatient competency evaluations and restoration is a way to free up beds. Only 6 states last year reported that they had plans to open new state hospital beds. And those beds that they described were all forensic or children's beds to address a specific need. What was interesting, though, was we just saw this week in the news that Washington State just came to an agreement spending $29 million to purchase a 137-bed private psychiatric hospital that had just closed a month ago. And the state's opening or buying that hospital with plans to use it for civil status patients to try and reduce the pressure on their 2 existing state hospitals, which are really focused on forensic clients right now. So there is some building of hospitals or reopening of beds, but they're mostly focused on the forensic population or trying to address that. If we look at the number of state hospitals over time, we see that over 140 state hospitals have been closed, and 92% of the state hospital beds, over 500,000 state hospital beds, have been closed since the 1950s. But when we focus only on state hospitals, we sort of miss all these other beds that have been closed over time. And what we see also is that most of the state hospital beds that were closed decades ago. The number of beds really declined from the 1950s to the 1970s, where we were down to 200,000 people. We were less than 100,000 people in state hospitals in 1980. And then since 2000, the number of people in state hospitals it's really been fairly flat in terms of the number of patients in those hospitals. So if we're attributing the recent number of people in jails or in emergency rooms to closing state hospitals, it's sort of hard to compute that with most of the beds having actually been closed decades ago. Another thing that's important to look at is who are in state hospitals historically. When you look at state hospitals back in the 1970s and earlier, there was an awful lot of people in state hospitals who were elderly, age 65 and over. And that's a group that's largely moved out. 96% of the people who were over 65 have been, the number of clients have moved out of state hospitals over the last 30 years, or excuse me, 50 years, from 1970 to 2020. For kids, there's been a decrease also, larger than for adults 18 to 64. Unfortunately, the data set that we use to look at the number of patients in the state hospitals doesn't have the elderly using the same series after 2005. So that's why you see the 96% decrease from 1970 to 2005. But I can't do a separate calculation just for elderly to 2020. Another way to look at it is what percent of the beds were closed in each decade. So of the state hospital beds, 65% of them from 1970 to 2020, 65% of those that were closed during that first 10-year period, 1970 to 1980. For adults, 70% were closed during that decade. During the 1980s, 1980 to 1990s, we see a lot more of the shift moving elderly people out of state hospitals as the share of the population. Overall, it's a 15% decline. And what we see overall, total beds from 2000 to 2005, a 2% decline, from 2005 to 10, a 3% decline. And then in that 2010 to 2020, there's only a 1% decline of the beds that have been closed over that larger period of time. So if we go back and look at that chart that looked at the number of people in state hospitals and the number of people in jails, the blue line are the number of people in state hospitals. You can see how it's gone down, but been largely flat the last few years. I think one of the important pieces when we talk to our forensic experts, in 1971, there was the war on drugs that really led to a lot of incarceration. And then in 1986 to 1988, there was this mandatory sentences for drug offenses, particularly with the crack cocaine epidemic. And that's really when we saw a huge number of people in jails and prisons go way up. Now, there isn't data. We've been talking to people at Bureau of Justice Statistics and places, can we parse out the people in jails who are there with a mental illness or with an addiction? That data doesn't exist. So again, that red line is everybody in jail, whether they had a mental illness, a substance abuse or not. But what we see is really the big increase in the numbers in jails happened quite a few years after a lot of the closure in state hospitals. 76% of the beds in state hospitals have been closed before the mandatory sentences for substance abuse offenses began. Another thing is to really focus on the patients in state hospitals today are very different. In 1970, and I had to go digging through a whole bunch of historical NIMH files, things that weren't online, statistical notes that they'd published. But what we see is that in 1970, almost 30%, 99,000 patients in state hospitals were age 65 and over. 24% of clients had what at that time was labeled an organic brain syndrome. That was 81,000 people. 45,000 plus of them were older adults. That's a group that I'm told now includes Alzheimer's and things, diagnoses that would largely now be in an assisted care nursing home facility, not in a state hospital. 31,000 people had a diagnosis of an intellectual disability, then reported to NIMH as a mental retardation. 18,000 some had an alcohol or drug abuse disorder, and that was from a 1973 report, so 18,000. So if we think today there's under 40,000 people in state hospital in a given day, there are many of these people that had diagnoses that would not be in a state hospital. In 2005, only 3.8% of patients had an intellectual disability. 3.6% instead of the 24% had organic brain disorder, and 5% of the clients had an alcohol or drug disorder. And we think a lot of those had a co-occurring mental health and substance use disorder. After 2005, SAMHSA stopped collecting their hospital series that had the diagnosis, so we can't continue to look at that to today. But by 2005, we see already this huge shift. And in 2014, only 8% of clients were age 65 and over. And it was interesting when I was presenting this and talking with NASMHPD about this, Dr. Hepburn, who's a psychiatrist, the executive director of NASMHPD, relayed that his first clinical, when he got through medical school, he was working at a state hospital, and they had a whole unit at that time in the 1970s that was for syphilis patients who had dementia as a result of syphilis. And that's another group that I didn't see in the NIMH statistics, but he said it was a sizable unit at their state hospital. And that's another one of those populations that would have showed up in the 1950s, 60s, early 70s data that's no longer a focus of any treatment in any state hospital that we've heard of. So if we take this data and we look at the number of patients in state hospitals by some of these diagnoses that really are no longer a focus of treatment in state hospitals, we see the light blue line at the bottom are the ID/DD clients. The darker blue are organic brain syndrome. The gold color are alcohol and other substance use related diagnoses clients. We see this precipitous drop from, they were over 120,000 people in state, or 110,000 patients in state hospitals, or 36% of the patients were one of those three diagnostic groups. And by 2005, they were down to 12% and less than 12,000 patients in state hospitals. Similarly, if we look at the elderly, we can see another way to look at it. They went from 29% of the population to 8.8% in 2014. And as I said, for the diagnoses, we can only look at that from 1970 to 2005, but we see this major decrease in people with organic brain syndrome, as well as what was then labeled as mental retardation and alcohol and drug abuse. So if we try and sort of adjust, this and look at the state hospitals patients served over time, there's been a 96% reduction in the elderly clients, 80% reduction in child residents, 79% reduction in adult residents over this 50-year period. If we look at the next slide, we see this decrease for these other groups, that really shows, the shift in who's being served in state hospitals. So if we look at the residents in state hospitals with and without diagnoses currently the focus of treatment, the blue line are including everybody in the state hospital, and the green line below it show if we take out the 36% of residents back in 1971 that had the diagnoses of mental retardation, intellectual disability, substance use, or organic brain syndrome, that really the number of beds that have closed over this time period is not nearly as large as it's often described when people look at the total use of state hospitals. And so this last slide, just shows the adjusted, if we exclude those other diagnoses, and we see just many fewer people, still a significant decrease, but not nearly the 96% decrease that's frequently described. This again is just another way to sort of look at the substance abuse people in the state hospitals and those three diagnoses. Oh, yep, I'm sorry. The other piece I wanted to add was there's, in addition to state hospitals, there's been this increase in other psychiatric beds over time. So while the states were closing their state hospitals, private psych hospital industry grew quite a bit. General hospitals opened up separate psychiatric units because of the IMD rule. They can bill Medicaid for patients that can't be billed in a state hospital or private psychiatric hospital. We have CCBHCs that are operating some beds. We have residential treatment providers that have beds. And so this red line are other beds outside the state hospital that are a focus of psychiatric inpatient treatment. And we see that those are now many more beds than there are in state hospitals. And so then if we finally take this last slide and you combine the state hospital and all the other beds that are focused for psychiatric inpatient treatment, private psych hospitals, general hospitals, et cetera, there's not nearly the same decline that's seen if you only focus on state hospitals. So if we want to look at all these other beds, adding in information about mental health treatment settings beyond state hospital beds, there are several data sources that you could use. SAMHSA does a survey every 2 to 4 years. They now are pretty good about doing it every 2 years that focuses on specialty mental health providers that reports on the number of beds and the number of patients in the bed on a single day. They've just this year combined a separate substance abuse and a mental health treatment provider surveys into one survey that gets both. But that will be getting information on how many people are in inpatient and residential treatment beds on a given day. And it breaks it out by kids, adults, elderly, as well as also by legal status, forensics or not. The Agency for Healthcare Research and Quality collects information on patients discharged from community hospitals by diagnoses. That's important because the SAMHSA data gets its specialty providers. If somebody goes into a general hospital and receives psychiatric treatment, but they're not in a specialized unit, they don't show up in the SAMHSA data, but the HRQ data set captures all data for people in a general hospital. And so it's a way to look at people that may be in what's often called a scatter bed. The Department of Defense and Department of Veterans Affairs each have their own periodic reports that detail inpatient and outpatient mental health services. We'll talk a little bit about CMS. Their nursing home resident survey collects information on people in nursing facilities with mental health diagnoses. In particular, their standard report highlights people with diagnoses of schizophrenia and bipolar disorders. And the Department of Justice is planning some new surveys of inpatients with mental illness in jails and prisons, but right now we don't have that data. And we've had some discussions with the American Hospital Association about their proprietary database of hospital discharges, which again would allow looking at sort of the scatter bed, people that aren't in a specialty unit receiving mental health services. For this paper, we really focus though on the SAMHSA data, which gets care in 2 inpatient related settings. So it gets psychiatric inpatient beds and what they call 24-hour residential treatment beds. And they collect that for a variety of settings: state and county psychiatric hospitals, private psychiatric hospitals, general hospitals with separate psych units, the VA medical centers, residential treatment centers for children and adults, and then other, which includes a variety of community providers that have some inpatient or residential treatment beds. Now, one caution is the current data does separate out inpatient and other 24-hour residential treatment beds. Earlier versions of the SAMHSA data combined the inpatient and other 24-hour residential treatment so that we can't really separate it out when we're looking at the historical stuff. But in the 2018 data, this was again collected patients in the state hospital or in any of these other settings on April 30th of 2018. And if you think April 30th, that's why the 2020 data I think was problematic, because that was right in the start of the COVID lockdown in April 30th of 2020. So the 2018 data I think is much more reliable, and then hopefully the 22 data as soon as it's out, and 24 when they do that. But what we see for inpatient beds, there were 129,000 people in total in an inpatient bed in 2018. Only 33,225 of them were in a state hospital. So it was the third largest group. Its private psychiatric hospitals were a much larger share, as well as general hospitals with separate psychiatric units. And if we look at for the other 24-hour residential treatment beds, we see residential treatment centers were, of course, the largest setting, but then other mental health providers, community mental health centers, CCBHCs, had quite a few of those beds. General hospitals had a few, but private psychiatric hospitals were still larger. So that the state hospital system was the fourth largest source for these residential treatment beds. So all told, though, there were 187,877 people in a mental health treatment bed on April 30th. And again, the state hospitals were the fourth largest setting. Private psychiatric hospitals, and then general hospitals, and then residential treatment centers were all larger than state hospitals. But the net was there was 57.4 people in a bed per 100,000 population. So if we look, back at state hospitals, it was only 10.3 inpatients per 100,000 population. But if you look at all the different beds together, we're up to 57.4 beds per 100,000. And with the SAMHSA data, you could look at it by individual state to see how your state compares with others. If we look at how this has changed just over the last few years, looking at their 2014 to 2018 survey for inpatients, we see this decrease in state and county psychiatric hospitals, but the number of people in private psychiatric hospitals had a major increase. The number of people in general hospitals with separate psych units increased. Overall, there was a 27% increase in psychiatric inpatient residents between 2014 and 2018. If we look at it for the other 24-hour residential, we do see a decrease, a 15% decrease in residential treatment level beds. The number of beds in state hospitals was a slight decrease. The big decrease were in residential treatment centers and in the other specialty providers that had inpatient or residential beds. Another piece that we were asked about was, what about nursing homes? There were a lot of elderly in-state hospitals years ago. Medicaid and Medicare did not exist until the late 1960s, and really were taking off in the 1970s, that would pay for care in a nursing facility. We looked at the CMS data, which shows the number of individuals in a nursing facility that have a diagnosis of schizophrenia or bipolar disorder. There were over 222,000 residents in a nursing facility with an active diagnosis of schizophrenia or bipolar disorder, which is about 46 per 100,000 US population. There were also over 819,000 people with an organic brain syndrome, Alzheimer's diagnosis in nursing facilities. These are people that likely may have been treated in a state hospital earlier. See, there were 61,000 some people in 1971 who were in state hospitals with one of those diagnoses. So just sort of looking at this, if we added the nursing homes in with the other beds, we see there would be over 282,000 some people with a mental illness in some form of a bed in 2018. So this just takes that data and adds in the nursing homes, 220 some thousand people, and we end up with over 124.5 rate of people in a inpatient residential treatment or a nursing facility bed with a mental health diagnosis in 2018. It's 2019 data for the nursing home information. Just want to note that. The other thing I want to focus on is there's been a big shift in the use of state hospitals by legal status. So in 2018, we see voluntary patients were only about 11% of the people in state and county psychiatric hospitals, 50% of the patients in private psychiatric hospitals, 56% of patients in general hospitals with separate psych units. The big difference you see, 54% of the patients in state hospitals were involuntary forensic status. These are people that are sent there for competency to stand trial evaluations, competency restoration. They were found not guilty by reason of insanity, some form of a criminal justice involved status. And so in the SAMHSA data, we see, the forensics, there were 18,000 people in a bed with some forensic involuntary status. 15,000 of them were in a state hospital, whereas the civil status, either voluntary or involuntary non-forensic, so they were civilly committed because the danger to themselves or others without any criminal charges, were 47,000 people, and those people were largely receiving treatment in private psychiatric hospitals or general psychiatric hospitals before they were in state hospitals. If we look at the legal status of patients, we see of voluntary patients how it's gone up for several years. The 2020, I did chart that, but like I said, overall it shows this big decrease that we think is largely more of the COVID impacting reporting. Involuntary non-forensic clients went up, and then the number of forensic clients has been fairly stable over the last decade. If we look at the legal status of people in state hospitals, what we've seen is mostly this decrease in the number of people that were involuntary civil status, where they've gone from over 18,000 people in 2010 down to a little over 10,000 in 2020. And also the number of voluntary clients. And so while the state hospitals were decreasing in overall size, it was largely the civil status patients that were being moved out of state hospitals. This is another way to look at it, to sort of what percentage of the caseload are voluntary, involuntary, non-forensic, or forensic. And we see that the forensic was up to 54% in 2018. In the 2020 data that were a little questionable, it was still over half of the patients in state hospitals were forensic status. This just looks at where forensic clients were. 83%, 83.7% were in state hospitals. A few were in private psychiatric hospitals or general hospitals with separate psychiatric units. Those were probably people for competency evaluations, restoration, but the data doesn't parse out what the type of forensic charges people had. And for voluntary patients, what we see, again, state and county psychiatric hospitals, only 6.3% of all voluntary patients were in state hospitals. The majority were getting care in private psych hospitals or general psychiatric hospitals, general hospitals with psych units. We did ask in our state profiles last year about legal status of clients that did try and break out a little more detail. We only had 37 states reported admissions and only 32 states reported on residents the first day of the year. And because of that, they're not the same states, so it's a little hard to make comparisons. We're in the process of updating this for 2023 right now. We worked with forensic directors on a survey and hope to get better data that breaks out who's really there for competency assessment, competency restoration, not guilty by reason of insanity, breaking out those forensic clients. But what we see for admissions, it's still a lot of involuntary holds and involuntary civil status. So people coming in, but in terms of the number of residents, people that stay there, over half are again residents were a forensic, involuntary forensic status or a sex offender status in the 20 some states that have a sex offender statute or some other such things. Let me run through quickly because I want to give Kristen time to talk about the model for how many beds are needed. Just there is information about how many patients are in state hospitals, so we can look at it by state. The purple states have the lowest number of state hospital patients per 100,000 population. The green have the highest number of state hospital patients per 100,000. This is a map, though, that looks at it. If we look at all the different inpatient settings and residential, the inpatient settings, so the private psych hospitals, general hospitals, et cetera, and the map changes. Some of the states that were the lowest before are no longer the lowest when you look at all types of beds that are available. And then similarly, if we look at the 24-hour residential treatment, again, the purple are the lowest number, the green have the highest, and we see the number of states that have that. And finally, this map combines the inpatient and other 24-hour residential. So we see, there are a few states. Alaska is a pretty small population state, but that may account for their high level. But California and Oregon, New Mexico are in the second to the lowest tier. And again, you could see which states have the highest and the lowest. And so if states are interested, we could share the state by state data for this with you. Last thing, quickly looking at expenditures for state hospitals. No data exists right now for total inpatient care. So we can't look at how much is being spent for private psychiatric hospital inpatient or general hospital psych units. But we have been tracking state hospital expenditures and overall state expenditures over time. So last time in 2019, there was $47.9, almost $48 billion spent by the public mental health system. If we control for inflation, though, it's gone up, but only from $6 billion to $8.2 billion. But we can look at it per capita, $144 per person in the country is having money spent. The states are spending $144.92 per state resident on mental health services. If we adjust for inflation, though, the public mental health system did not keep up with medical inflation. So we've gone from $26.78 per person in 1981 to $24.27 today in inflation and population adjusted. But we can look at it, what's spent for state hospitals or community. What we see back in 1981, which was the year before the block grant took effect, states were spending $3.9 billion on state hospitals. They're at $11.5 billion today. We often hear states took money out of state hospitals. That's really not correct. They're spending 3 times more today than they were. But what's really happened is there's been this phenomenal growth in community mental health service expenditures that's gone from $2 billion in 1981 to over $34.4 billion today. As a result, we see this big shift. Back in 1981, 63% of spending was in state hospitals and 33% were for community. And today we're at 73% of spending is for community mental health, and the state hospitals are 24% of the state mental health agency budget. Again, if we look at the state hospital expenditures controlling for inflation, though, we do see that while it's gone from $3.9 billion to $11.5 billion in total dollars, controlling for inflation, it's dropped by $2 billion, controlling for using the medical inflation index. So we're down to $1.9 billion for state hospitals. I do want to point out that, 1.6% of the clients that the state served, they served over 8 million people in 2019. So 1.6% of those people were served in state hospitals during the year, but 24.5% of their expenditures went for that. So it's a very expensive service for people that have that very high need. But that's one of the reasons I think states are very interested in how we can divert and make sure that the state hospitals are used only for people who need that most intensive level of care. This shows overall per capita expenditures by state. The blue is the state hospital, green is community. So we see there is a wide variation across states and how much they're spending. for hospital versus community, and that's all available also if states are interested. Total per capita spending for mental health. And then this map looks at the per capita spending for state hospitals. You could see how much spending is going on. And the number of state hospitals, the blue are states that only have one state hospital. So there are quite a few states where there's only one or two state hospitals. And those are states that are unlikely to do any additional closing of state hospitals. But they may still be doing some downsizing or reconfiguring, as opposed to the green states have 7 or more state psychiatric hospitals. With that, I'm going to sort of break out a little bit about the funding. The state hospitals, because of the Medicaid IMD, rely much more on state general fund. The community system is much more reliant on Medicaid. Over $21 billion of Medicaid is supporting community mental health services in the public system. The block grant is 0 for state hospitals. It's statutorily prohibited from being used for state hospitals, but it was $500 million. It's now gone up quite a bit with this last year COVID supplements, and the Biden administration's increasing the block grant over $1 billion. But with that, I really want to shift to, we're right now in the process of collecting some information from states about how they're using state hospitals. We're launching a major survey that we're doing in conjunction with SAMHSA's Center for Financing Reform and Innovation, looking at competency evaluation and restoration done outside of state hospitals. So trying to look at what states are doing in community and jail-based evaluations and restoration, who's doing it, what it costs, how well it's working, as well as diving in more to, in the state hospital, who are forensic and what are their various forensic statuses. So that information will be available later this year. But with that, I really want to turn to Kristen, because last year I worked as part of a task force that the American Psychiatric Association put together to try and look at how many beds are really needed across the country. And Dr. Deb Peinels, who many of you know, was with NASHPD and with Michigan Department of Mental Health, and I were both part of this panel. And they had several work groups that looked at what's been happening in beds historically, trends. But then they had a group of operations researchers that were really trying to model and do simulations for how many beds do you need that really moves beyond the simple formulas that many states have used, that you need X number of beds per 100,000, but really that delves into, as you roll out a crisis continuum, as you roll out assertive community treatment or first episode psychosis, or programs that are known to impact hospitalization, how does that impact how many beds you need? And so with that, I'm going to turn it over to Kristen to talk about this exciting work.
Great, thank you, Ted. Ted, there's a couple questions in chat, so I might ask you to take a look and see if you can respond. There are a couple questions about some data trends that you shared. And thank you for really grounding our understanding of what's going on in important data. So my name is Kristen Hassmiller Lich. I met Ted in working on the APA task force for bed need estimation. I am in the Department of Health Policy and Management in the School of Public Health, Gilling School of Public Health at the University of North Carolina. I am cross-trained in public health and in industrial and systems engineering, and partner with systems engineers to try to bring simulation modeling and decision support modeling and system mapping to bear on really complex public health challenges, of which this certainly is one. You'll see in the bottom right of this slide my contact information. Please don't hesitate to reach out if you have questions or want to explore whether this direction might be useful in your context. So I want to talk to you a little bit about what we're up to. So I've been applying decision support modeling, computer simulation modeling, and system mapping to study acute crisis mental health systems here in North Carolina for the past 15 years, off and on, and was really excited to try to take what we've been learning down here and look at what's going on nationally through this task force. So I just want to talk a little bit about computer simulation and what it is. If you could click the play button here, we'll get this moving. This is a real simple little video of a running model. where on the top we have a restaurant, think about Panera, or it could be a bank, just some sort of a service system. On the top and the bottom, I've got equivalent systems working, a model of equivalent systems working. The only difference is that on the top, we have 4 servers, on the bottom, we have 5, but in both cases, a customer arrives every minute on average with a little randomness variation. Service takes an average of 3.8 minutes with some variation. All that differs is whether we have 4 servers or 5, and you can see a picture of the wait times, the little people waiting in line for a server and moving through this system. You can see that changing over time. On the right, we're keeping track of the average time in the system for the version of the world on the top and on the bottom. And you can see that, on average, people spend 22.5 minutes in the system on the top and 5.3 on the bottom, 3.8 minutes of which is getting service. I'd much rather be interfacing with that system on the bottom. And building computer models like this is really valuable for so many different reasons. First, it pushes us to see if we can represent the system. We're pulling together all sorts of different snapshots of data. How many customers do we think we have? How much time do we think service takes? We're putting it together in a simulation model and trying to see whether it matches reality. Does it look like the system that we are living in, that we observe? If not, why not? What are we missing in the structure of this model, which is a simplified version of reality? But once you build up a model of your system that you believe in, then you can use it for all sorts of experiments. We could start to ask, what if questions? What if we added another server? What if we had a way to try to reduce service time by giving people menus, on their phones, so they don't have to wait till they get up to the front of the line to see your too small menu? And we can come up with all these strategies for improving how things are working and then test them out in the model. When it comes to what I'm going to call queuing models, queuing systems, which is really relevant in our acute crisis mental health system, there's only a couple of components to these models. It's a lot like the example that I'm showing you. So we have to understand how much capacity we have in our system. In our case, how many inpatient beds do we have? How often do people need, does a crisis happen that warrants admission to those beds? How often does that happen? How long is length of stay, right? How are we pulling people out of the waiting lines? Are we prioritizing in a certain way? If we know this information, we can build up a computer simulation model of how our system is working. And as you all know, it's not just one line, one service, right? If we're talking about the acute crisis mental health service system, there's a series of interconnected service points, right? And not everybody needs the same thing. But the models are no more sophisticated. It's just that we're putting these pieces together to help us understand how the system's working and how it would respond, how do wait times change if we adjust capacity in different parts of the system. So this is the idea of using computer simulation to inform our decision-making, kind of in general. I had the opportunity to work on a project several years ago where when a lot of states were getting sued about not having enough competency restoration beds and taking too long, we built up a real simple model. And in having conversations with a number of states, we realized that this is actually a pretty straightforward system. It is one unit of service. So how many competency restoration beds units do we have? How many people per month are arriving into our system where we need competency restoration, and how long does it take? We may have 2 parallel versions of this system running for more and less violent folks, or separated by type of offense. There may be different reasons why we might, segment our competency restoration systems, but we can model them really well by just considering these parts. So we built up a little computer simulation model, and I have just learned that UNC, which occasionally deactivates some of these older links, has done that. So I need to get this live again, but the link is going to be here in the bottom left corner of this slide. We created a little decision support model. It's a queuing model, and there are 3 different tabs. And what you do with this model is you can plug in any two of the three parameters that we really need to model the competency restoration system. So we could say how many people are added to the wait list for competency restoration per month. The top cell in green in the middle top. We can add in the length of stay on average, and then we could try to figure out, how is the average wait time going to vary as a function of how many beds are available between 41 and 60. And we can go to different tabs and we can lock down two of the different parameters and allow another one of them to vary. And so using this model, what we can do is ask questions like, okay, so imagine we had a system that has 32 people arriving per month needing competency restoration. The average length of stay is 60 days, and we have 65 beds available for competency restoration. We can ask, how much of a change would be required in each of these three different other parameters? Demand affected through diversion. Service time may be affected by being a little more efficient in how fast we move people into competency restoration beds that are available for them, or adding beds. How much of a change do we need to make in each of these three different directions to get our wait time down to below 1 week? And what we learned, pulling data from lots of different states, is a lot of them are operating very close to the tipping point. These kinds of queuing models tend to have tipping points. Things are really bad until you get just enough capacity, and then the wait times dramatically fall. So a lot of our systems were actually really close to those tipping points. And so we could, with the model, learn things like, well, okay, so the three options, how much does it take? If we decrease demand to get below 1 week, we have to divert 1.75 people on average out of the 32. If we reduce length of stay, we'd have to get it from 60 days to 57 days, so a 3-day reduction. If we add 4 beds to our 65, we can get that length of stay, that wait time for competency restoration down. And so now you can have a conversation in your community or your state about which of these directions is going to be easiest for you. And we could add costs and all sorts of information to the model, but we wanted to keep the model really simple so that people could use it to figure out the magnitude of changes that are required to get wait time below a desired threshold. Okay, so that's the idea of these models. So this task force was going on, and wait a minute here, Ted, I think this might have been your transition slide that I threw into mine. Let me just talk about, so there was the task force was going on, the American Psychiatric Association Presidential Task Force on the Assessment of Psychiatric Bed Needs. And there's some information here about it, including a link to see more. And here, again, is just a little bit more of a description of the task force report from that link. If you follow that link, you'll see the report here. You can download the sections or chapters or the complete report. But the goal was to really try to initially write an equation to estimate the number of beds that would be inpatient beds that would be needed to address demand, congestion, and occurring in many of our states. And what the group realized, which led them to bring our team into this work, was that it's not as easy as an equation. That we really need to understand what other aspects of the system look like. So Ted showed us some wonderful data that it's not just state psych hospital beds, and it's not just other inpatient beds. It also matters, how much capacity we have in step down programs, that if they're available, someone could leave a hospital bed sooner, or how much mobile crisis work are we doing, or ACT team capacity do we have to try to prevent crises or divert crises in the first place. It's a delicate balance, of all of the different components of our crisis continuum in place, and characteristics of the population that are going to affect what's needed. So we wanted to try to explore what it would look like to bring a computer simulation model into this decision-making space. And so I want to just show you a little bit about what this looks like here. So we started out in the task force report focusing on defining that our focus was acute mental health crises. And we had a lot of conversation about, could it be in the whole population? Or we initially chose to focus on adults age 18 and up, recognizing that the structure of the system, there are some similarities, but there's also a lot of differences between the adult and the pediatric systems. So a lot of this early modeling kind of prototype work was with the adult acute mental health crisis service system. But we did circle back around and really start to talk about what this all looks like on the child side. But we were focused on the acute mental health crisis system, where this is defined as a mental health crisis, defined as something, a crisis that requires something more than a typical outpatient or phone intervention. Okay. And then we went on to talk about, well, what are the other components of an adult acute mental health crisis service system? And it turns out, you might think that that's an easy answer, but it's really not. We all have different words that we use in our communities for different aspects of the system. We have different models for what things look like. Sometimes we use the same word to mean different things. Sometimes we use different words to mean the same things. It's hard. So we spent a lot of time trying to come up with a common vocabulary for the key components of an acute mental health crisis system that seem to be generalizable to many of our communities and states. So the model includes mobile crisis, intensive team-based care, ACT teams, mental health crisis receiving centers, community-based crisis beds, mental health hospital beds, whether they're in a state psych hospital or a community hospital, whether they're inpatient psych or a med surge bed with psych support, and step-down programs. I'm going to walk through the system structure diagram to show kind of how these all sit together, which I think is really important. If we're trying to understand the mental health system as a system, we don't want to just list the parts. We want to think about how they interconnect. And you will see that very quickly things get big, they get complicated. So we spent a lot of time talking about what's that right level of detail to bring into this work. How much lumping and splitting do we need to do so that we can really center the conversation on the decisions that communities and states are needing to make? And this is where we initially landed. We're in the process of applying this model, really adapting it to guide decision-making in some specific locations. And these decisions that we made kind of nationally are being opened up again. And what we're finding, though, is to a large extent, this kind of structure still feels really right. In some of our communities in a region of Michigan that we're working in, they don't have a mental health crisis receiving center, but they do have a psychiatric emergency department. And it's really kind of functioning in the same way. So we're using this structure to represent that organizational unit. But a lot of these elements are present. So the structure of the model is working really well. Okay. So what does it look like when we try to put these system components together? I want to go through a system structure diagram with you. This is using some notation from system dynamics. It's a method that we're using, and I'll talk a little bit more about why we're using that method in this work. It gets big real fast, so I want to try to build up the parts. The light blue boxes that you're going to see, including this one, they are depicting accumulations, or we call them stocks. They're the numbers of people that are in different parts of the system at any point in time. If you were to freeze your community or your state's acute mental health crisis service system, it's trying to keep track of where people are at different points in time. So we have a certain stock or number of individuals, adults, in acute mental health crisis waiting in the community. So those are the light blue boxes. We have pipelines that go into and out of and ultimately between these stocks, the light blue boxes, and those are keeping track of how people move over time. So, for example, when individuals in community have an incident acute crises, those crises flow in, people flow into the community where they are in crisis until they move into another component of the service system. That little cloud to the left, what that means is that we are not explicitly modeling where those people were before. We are keeping track of how many individuals have an incident acute crisis in a given day, in a given week, but we don't model where they were before. For example, you might want to think about how well integrated they are in or what kinds of community outpatient services they're using. We decided that modeling the details of the outpatient mental health system was out of scope for this project. We start where the incident acute crises, once those happen. But we can adjust that rate, that inflow of people having an incident acute crisis by characteristics of the outpatient system. So if we are modeling a community with a more adequate, a stronger, more accessible, higher quality outpatient services available, then we would expect that would reduce the number of incident acute crises, all else equal. And if we have a system, a community with a poor, inadequate outpatient mental health system, then you would expect the number of incident acute crises to be higher. And there are other variables here that are connected to that flow, just showing us that they are part of the equation, where we're calculating the number of incident acute crises. So things like on the top, the number of adults in your community, we've got a rate, below an average rate of incident acute crises per 100,000. And we're also adjusting this incident rate to take into account the adequacy of basic necessities of living in a community. So for example, if you have a lot of housing insecurity, you're likely to have more incident acute crises. So we're trying to think about what are some important dynamics that are going to help us adapt this model to your context. We also see pipelines. When I say the inflows and the outflows, it's the parallel lines. It looks like a pipe, and that little hourglass on the pipe is meant to be a valve. And it means that there are things that we can do to increase or decrease the rate of flow. So people can flow out of the stock of individuals in acute mental health crisis waiting in community if, for example, they're stabilized through mobile crisis. And they're not moving to a specific place. Mobile crisis comes to people depending on the capacity of mobile crisis services available and their quality of care, the ability of what they're doing to help stabilize people. Some individuals in acute mental health crisis will move out of this system, right out of the community. Others might get arrested, the pipeline on the bottom, arrested while in crisis. And some of them will need competency restoration. That's going to be shown more in other parts of the diagram. I'll explode here in a second. Others won't, and they're going to be out of scope of our model. Okay, now we can start to build in other structures, other parts of the system where people flow. So individuals who are in acute mental health crisis with some amount of time passing will move one of two directions in this typical, in this realistic but not real simulated community. You might move into an emergency department or the bottom arrow, a mental health crisis receiving center. And then from there, you need to think about how do people move back and forth between those. And what are the next steps in the service pathway? Some people might be stabilized in the emergency department and move out. Some might leave not stabilized, and a subset of those might end up arrested. Other people in the ED may end up hospitalized. Similarly, the crisis receiving center, you may end up being transferred to the emergency department or over to a community-based crisis bed. And from there, people might be discharged. We keep going. We add in here a little bit further over to the right. Skip that. Over to the right, that up at the top, at the ACT teams, intensive team-based care, what that's doing is actually pulling some subset of the population out and providing more intensive wraparound care. And what that's going to do is reduce the number of incident acute crises and also make sure that it's going to shift how they flow into the crisis service system when a crisis occurs. They're going to go down the path that's likely to be the well-matched, better matched to the intensity of service that they need. So that can improve how this system functions. So over on the right, then we have the step-down services, which might also be described in our communities as step-up, depending on how they're used, right? But we're just modeling the capacity that they make available to serve in the system as a step down. So if these slots, if these partial hospitalization program slots or IOP slots are available, individuals could be admitted into them and discharged from a hospital sooner than they would have otherwise. And that's got a really important impact on how well our system is functioning overall. Okay, and then down on the bottom, we modeled in the competency restoration part because I think a lot of our communities are feeling this as a pain point, that the competency restoration queuing, the wait times are too long. And so what they're doing is they're pulling, in some cases, civil capacity to address that problem. But unfortunately, because everything's interconnected, and what we can show with this model is when you pull civil capacity over to the forensic side to deal with the competency restoration problem, it's going to back up the civil service side, and we can start to quantify how much. And it's really meant to be kind of a warning against doing that without, bolstering other, components of the system that are gonna really prevent some of the civil side crises. Okay, and then the model is simulating a number of different outcomes that we care about. These are indicated in plum text, and I'm going to show you a dashboard in just a second to try to give you a sense of how these simulation models help us see the system's behavior over time. Just a little bit of information about what's happening under the hood. The model is big and messy. I'm just showing a snapshot of it over on the right. It's built in system dynamics software, but there's no magic in the model. It's really just how I talked before about a queuing system as putting together information about demand, capacity, length of stay. It's really just pulling together all of that information for the different components of the acute mental health crisis service system. So the model helps us do that kind of mental work to understand how the pieces fit together to affect outcomes. And I should say it's really important that we've made decisions to be very deliberate about trying to build up a model that will help with our strategic learning. We're not trying to model every detail within a community. What are the specific emergency departments and which ones flow into which hospitals and where we're really trying to aggregate and look bigger picture at the level of capacity in the different system components and trying to understand if we've got the balance right, or if we made changes in different components, how does that affect things overall? We're trying to stay at this level of a strategic learning model and using it to guide decision making and help people question kind of their thoughts about what the cause and effect relationships are between capacity in different parts of the system and how it's going to function. So the model has dashboards, and here's a snapshot of what this looks like. Here's a real simple one with just 4 different outcomes. So on the top left, number of individuals in the emergency department being treated. You can look at what that looks like over time. On the bottom, the number of individuals in the ED boarding. Over on the right, we're looking at a very boring graph that just tells us that the civil hospital bed capacity utilization is 1 all the time, meaning it's maxed out all the time, and the number of individuals in crisis who are arrested and might have been divertible. We can see what that trend line looks like. And the more kind of congested and stuck and jammed our system is, the more we're likely to see this. Over on the left, what you see are sliders, and you can change different components of different capacity in the different components of the model and see how it's going to react. In reality, there's a lot more going on in the dashboard that different decision makers in the community care about. So we have a much more complicated dashboard. I wanted to start simple just to kind of give you a sense of this, but we really, on the left column is all about the emergency department. So number of people waiting over time spent in the emergency department waiting, the number of individuals boarding, time spent boarding in days, and then looking at the capacity in the emergency department. The middle column is the same thing, but on the community side, our crisis receiving center, community crisis beds. And over on the right, we've got a series of trends that you might care about in the community. So civil hospital bed capacity, we already saw. Community crisis bed capacity utilization, or how full that's jammed to. Number of people in crisis arrested individuals waiting competency restoration and competency restoration bed capacity. And I just want to show you a little bit of what this looks like, because now, if you could play this, the power of the model is its movement, is our ability to see, you know, does this model, this representation of our system's capacity look like, you know, look right? I'm showing you, I'm circling with the cursor in the bottom left, the slider that allows us to change the random number seed. And so what that's doing is it's just changing the string of random numbers we're feeding into the model. And so as that varies, you can see what a system with the same mix of capacities might look like. That gives you a sense of how much variation we might expect to see in our system over time with the capacity that we have. And then if you start to move the sliders around the mobile crisis teams, if you move that up, you can, you know, answer the question of like, how much of a change would we expect if we go from 0 to 1 mobile crisis team up to 2? And how does that compare if instead we move the number of intensive care teams, you know, down? What is that one that we have doing? What if we increased it up to 1? And the hope of the model is that by allowing people to interact with it, you'll learn. You'll start to be able to check your mental models, your ideas of how the system works against this, you know, computer-based decision aid, and that you can have better conversations and get to a better business case around how to right-size things in your community. I have the same video for the larger dashboard, but I'm going to skip that because what I want to go to next is really just the bigger vision, how we've been using this model in communities. What we want to start with, if we were to, you know, go and work in a new community, what we want to start with is really understanding your system. So begin by working with, you know, trying to bring together all the different perspectives that need to be considered in your system. What this has looked like in the handful of communities that we've been working in is you're trying to bring together folks from the emergency departments, the inpatient beds, people that are working on the crisis in the different crisis service components, the step down systems, people that kind of understand, you know, maybe they're patient advocates helping to navigate the whole system. We want to try to bring together, interview or bring together in a single meeting. We're bringing very structured system mapping methods to really try to understand, help people understand how what each of the different system components does. What's its role in this acute mental health crisis service system? What are the capacity constraints they're bumping into? What are the other pain points? What are the characteristics of what's going on locally that they are incredibly grateful for? Because if they didn't happen, if somebody else in the community wasn't doing this thing or providing this resource, they'd struggle. We need to know what those are because we want to keep them going. We want to hear the pain points, but also appreciate those strengths. And along the way, we're trying to estimate the model parameters to get a sense of what your system looks like in terms of the capacities and the wait times. So we started out doing these interviews focused on the numbers and getting the model right, and realized that, I think as much as the decision support model is useful, I think it's almost as, if not more important, just to get your local system stakeholders together, talking and appreciating how they fit into this broader context, this broader system, and how they're interconnected, and how they can optimize and improve upon some of those interconnections to get things working even better in their community. But after doing that system mapping and work to understand your system and get the model adapted, what we want to do next is engage, is help folks, those same folks, engage with the decision support model. I think, I just yesterday came back from the region in Michigan, and they're trying to decide. They had started to build a crisis receiving center and ready to open it up when COVID exploded. It didn't open, and it's still sitting there. And now they're trying to decide how to use that space. Should they go forward with opening the crisis receiving center, or is their psych emergency department enough? And or should it be kids or adults? If all these decisions, and everyone we talked to had a different opinion. And so the goal is, by engaging with a model like this, we hope that it will help them come to an agreement on what is going to really help the region's acute mental health crisis service system work the best. And then, I kind of jumped ahead there. So again, it's helping the decision makers interact with the model to learn, but with the goal of trying to improve their decisions. And what we're finding is, you get started with this work and you understand a part of the system. We're working right now on the adult crisis system in Michigan, but I think hot on the heels of that, we need to expand this and start to look at the kids system. We need to move beyond kind of mental health primary to also look at substance use because they all interact. But by doing a very structured kind of deep dive in the pieces, we'll start to understand the whole a lot better. And so with that, this is Ted's information here. My email address was earlier, but I want to open it up to discussions and questions.
Thank you,
I have a
Kristen.
question. This is Ken Mort from the New York State Office of Mental Health. And one thing that really complicates doing this for us is really kind of determining what capacity is available in these different systems to a specific population. I mean, there's the obvious things about insurance coverage and things like that, but then also kind of the spatial or travel time work on this. We have a hospital here with beds, but it's 200 miles away from this population here. Or when you look at something like New York City, we have a very rich transportation system here, and you can access things in many parts of the city on a 45-minute subway ride. Has anybody started to do some work integrating these those kinds of concepts of access into these operations research models?
Yeah, you're asking such a great question, and I think, well, I'll just say a little bit of a backstory. The first decision support model I built up to really inform kind of mental health, we went down the path of a very detailed place-specific model. And it's so data, and it can be so data, the kinds of discrete event simulation models we often see our emergency departments using, how do we, and the issues you just brought up complicate that. Things change as fast as we get the data we need to, simulate that. So we've been very deliberate about trying to stay at a higher level of abstraction to try to understand kind of the force of things. But we have to really consider exactly what you're talking about. So, and I think it just takes conversation. So in this region of Michigan, we had a conversation. The first conversation is how open versus closed is your system? It's an area with an academic medical system. And so we've got a lot of people coming in from outside this region, right? And so that affects capacity. And so we're doing things like, well, when we figure out how much capacity is available inpatient in the model, we're making it change from day to day based on what we see census for this region's residents to look like. Right. So I think what we really need to do, this first step, understand your system, is where we've got to talk through those complexities and find out the best way to represent it. I really believe that we can build very useful decision support models to capture kind of the estimates, approximates, get us really better in our thinking without having to capture all those details. But we have to represent things as well as we can, at least to make the model credible. So yeah, so the way we've handled this in this region of Michigan is that the capacity is not fixed, that often a lot of the beds are used by people from out of the region, and so they're just not available. But then on the flip side, some of our region's residents go out of. Yep. So we try to get a sense of how much of that is happening. And we're separating out. So this is a change to the model that we're going to make for them. We're separating out inpatient stays that are in the region and out of the region, because it might not matter if you think that it's got similar wait times. It just, you go to one place or the other and then you move back into the community. But it's really important there to separate it out, because I think what they're concerned about, what we're hearing, is that folks from this county that go inpatient out of the region, they are not getting as well connected back into the community system, and therefore are re-entering the crisis system faster.
Yeah, so that makes a lot of sense. Wow. Yeah.
Yeah. So what I want to communicate is that not all of the complexities that are in our systems have to be included in the model for the model to be useful, but we need to talk about it and think about how to represent it and understand how, the simplifying assumptions that we're making bias the results. Does that make sense?
Yep. And in truth, down the road, we look for opportunities to incorporate more advanced methods and things like that to be able to actually, mathematically take them into account,
Absolutely. And sometimes you need to do like little deep dives to model some smaller part of the system. And you can do that separate from the, the big, the tension here is that this model, our systems are complex and the model gets really complex really fast. So always trying to kind of push back and get just enough in there for it to be useful.
Yep.
One thing that we have also found, and so we're doing this work in this region of Michigan, hoping to expand locally here in North Carolina and in Oregon has really started kind of moving, and would love to talk to others about, where you might want to start to think about applying this. But it's fun for me because I'm starting to hear about the different decision support needs and the differences in the system that help us kind of build up a model that's going to be more useful to take to a new place. But one thing that has been invaluable is, while the model needs to be a little bit simplified, just like that little competency restoration model, the system mapping does not need to be. And so we are having, really having in-depth conversations and trying to document the insights in summary tables and drawings of how the system functions, so that people can keep it in their head, and then we can make better simplifying assumptions, but keep those kind of going. Does that make sense? The abstracted model, but the detailed system map.
Yeah, the other thing that I've also thought about on this, I've been very interested in many aspects of other things in operations research to do this kinds of stuff. And one of the things that I've always kind of run up against is once we start to create these models, and you can't take into account, this in migration, out migration, all that kind of stuff, but go back and see if we can test our model on what truly is a closed system. There are many governments that no, it is a closed system. You get your services in this catchment area. That's how it is. And also in Europe, there's many systems that are completely closed like that. And I think those are great opportunities to validate the simplified models to make sure that we're on track with it, and then possibly start to take into account being able to apply it in areas that are not closed systems,
Right. I love it. Yeah, please reach out. I think that's such important work, and happy to play. Yeah, and I think and just again, we often have these conversations about, can I reasonably use this for the state level, where I think we've got to test it and learn how much abstraction is just too much for this.
I absolutely think you can use it at the state level by summing up the components down below. I absolutely believe that.
I agree with that. We just have to be aware that, when you lump so if you had one single hospital in the state, right, it would be way easier.
Yeah.
It's going to be more efficient because everybody has access to it. You can keep, but whereas you take that hospital and split it into three regions, it's hard. Any of those might have different demand at different points in time. You can't carry as high of capacity in those three as you can in the whole. Anyway, there are some things that you just have to be aware of when you're aggregating up to that high level. But I think it's better than what we're doing, which is keeping it all in our heads.
Yes. And my thing is, I tell people, we're never going to get beyond where we are if we don't start trying to do this. I kid you not. I love it. We are going to get nowhere if we just say, no, it's too hard, it's too complex. You have to start somewhere if we expect to be able to get anywhere.
Yep. I'm seeing a couple of the questions in the chat. I love this. Please reach out. We are working on a children's version of this model. We've got the system structure diagram and are working on that largely in the Oregon project. I think that's where it's going to happen first, but North Carolina is also very interested in this. And there was a wonderful question about how workload comes into play. So early on, 10 years ago, when I was doing a lot of this work, workload wasn't really what I kept hearing was the constraint. I kept hearing, well, we can hire maybe inefficient use of workforce. Like we'll hire people at these minimum staffing requirements and then hire temps to come in to get to where we need. So we were paying more for the workforce, but we had it. It wasn't a constraint in terms of whether or not we could have a bed or admitted patient to our program, but it certainly is now. And so we're starting to think about how the workforce enters into all of this simulation because it absolutely needs to. So I think that for the for the simple competency restoration model, I think that you need to keep into account not just how many rooms are available, for the competency restoration, but how many staffed rooms. So that's a simple answer, but we're starting to do a little bit of modeling on using the same methods on workforce capacity and how do we try to address like the stock of workforce. There's inflow, outflow, and we are going to grow our workforce as long as the inflow is greater than the outflow. So what are our strategies to influence both? Reduce burnout, increase inflow. It's absolutely got to be a part of this work.
I think that's key because, I mean, we're hearing that, talking to states where they've got, units closed, 30 beds closed because they can't get enough staff right now. And, initiatives to grow the workforce, but it's a new constraint that we hadn't heard in the past, that they just can't get enough people to have some of the programs open. We hear the same thing on the community side.
And then we also have, I see the problem on the community side. We've got a big trend towards per diem staff. And in all honesty, I feel we lose a lot of the therapeutic relationship when you start moving a lot of your like clinic treatment and stuff like that to per diem, where you're getting a new therapist every 9 months. So workforce is a tremendously complex and hard issue right now for us and everybody.
Yeah, I think you need to think about, again, with the model, what is it hitting in the model? Is it decreasing the quality and access of our outpatient system, therefore increasing the number of crises? Is it compromising our ACT teams? I mean, the same thing that's happening that I think we need to figure out how to better capture in the model is that as things get more congested, we're pushing back more and more acute patients into the lower level services. So a lot of our ACT team, I'm hearing over and over, ACT teams, mobile crisis, the partial hospitalization, we're seeing more and more acute, like a higher acuity. And so it's just, that has workforce implications too. I think we're right at 3 o'clock.
Yep, Kelly, you're muted, but yep, okay.
Thank you so much, Ted and Kristen, for today's presentation. I see there are a few questions that we might not have gotten to before the end of the presentation, so I will share them with you and maybe you can answer them, and then we'll send the responses to everyone when they receive the copy of the recording link and the slides.
Yeah.
When you all exit the presentation today, please take a moment to fill out the evaluation for us and let us know what you thought about today's webinar. Thanks again for joining us. Special thanks to SAMHSA for allowing us to share this information with you, and enjoy the rest of your afternoon. Take care.